A warm good evening to respected seniors, colleagues, and dear students. So through this platform, I would like to share our initial experience in robotic arm-assisted PET-CT guided biopsy. In this era of precision and personalized medicine, where the needle biopsy of a diseased tissue has an instrumental role in the diagnosis and further management of the patient, PET-CT guided biopsy is a newer technique to achieve this. The first PET-CT guided biopsy can be dated back to 2008, done in MD Anderson Center, but that was a non-robotic one. So let's begin with what is a metabolic biopsy. It is taking the tissue sample from an area of highest radiotracer uptake. So the radiotracer which we are going to discuss throughout our presentation would be the FDG, because it's the most common PET radiopharmaceutical in use. So what is the need of the metabolic biopsy? Now, this is a well-known fact that during a disease process, the molecular alterations occur much before the morphological changes. Thus, and the principle of nuclear medicine pharmaceuticals are that they get trapped in the areas of these subcellular or the molecular level changes. So if we target these areas of increased radiotracer uptake, the chances of early diagnosis and thus the staging of the patient is better. Moreover, a lesion may not always have a uniform radiotracer uptake, and here the FDG uptake, because there are associated necrosis or hemorrhage or fibrosis during the disease process, which will be non-radiotracer avid. Moreover, there would be multiple lesions either in the same organ or in the different areas of the body, which will likely show uniform attenuation on CT or the echogenicity on an ultrasound, but they may have a variable FDG uptake because of the tumor biology. And the last is those rare cases where the anatomical imaging may not be the anatomical changes may not be evident on the cross-sectional imaging, but they have a high uptake on the PET-CT. So in all these conditions, the directing of a needle in the area of highest metabolic uptake will definitely be an important will definitely lead to the representation of the tissue of the disease process, and hence will be resulting in a better diagnostic accuracy of the procedure. Now, till now I talked about the metabolic biopsy, but from now on what I'll say will be a real-time metabolic biopsy, that is which we are doing in our institute. With the real-time or the intra-procedural metabolic biopsy, I mean to say that the FDG PET-CT is done just prior to the procedure, and the entire procedure of the biopsy or this intervention is planned based upon this latest PET-CT, and the accuracy of this procedure is also checked simultaneously with the fused PET-CT images. The entire procedure I'll be telling in some time. Now let's see a few representative examples of what I discussed before on the metabolic biopsy. Now this is a large mass in the lung, and you can see that the uptake of the radiopharmaceutical is not uniform throughout the lesion, but there are only 20 to 30% of the lesion is having FDG uptake. So if the lesion is targeted in the center of this disease, then the sample may likely not be very diagnostic will not have a diagnostic report. Hence, the needle should be directed from the area of the maximum metabolic uptake. Another example, now these are two nodules in both the sides of the lung. The nodule on the left, in the left lung, appears a bit bigger than the nodule on the right lung, but it is the right lung nodule which is having FDG uptake. Hence, the biopsy needle should be targeted at this site. Now, this is an example where the CT changes are not very evident. Now, see, this lesion is a pleural-based mass which is extending into the paravertebral region, and it is uniform in attenuation. So, a CT-guided biopsy can be done anywhere throughout the lesion. But the uptake is actually only on the paravertebral aspect. So if the target is at this area, the diagnostic yield or the diagnostic accuracy of the lesion is supposed to be better. Another important concept of the PET-CT guided biopsy is we can always confirm whether we have taken the actual sample of the deceased tissue in the vial by the measurement of by the detection of the radioactivity in the tissue vial, in the sample vial. For example, now this was a lesion and we took the PET-CT guided biopsy, we placed it inside the sample vial and we placed this vial under the PET-CT scanner. Now on the CT you cannot differentiate whether the deceased tissue or a normal tissue has been taken. But if there is a presence of radioactivity in the vial, it means that the biopsy is successful. If there is no activity in the tissue vial, then means that we need to take a rebiopsy of this patient. Now the few indications of the PET-CT guided biopsy which we follow in our institute are new enlarging or PET positive pulmonary lesions which are more than 1 centimeter in size, and they are either not amenable to the bronchoscopy or CT guided intervention, or new lesions which are more than 1 centimeter of size and there is a suspicion of malignancy irrespective of the other anatomical imaging modalities. Another very important role of the guided biopsy is in cases of new multiple lesions with either not known malignancy but it's highly suspicious of malignancy, or there has been a prolonged remission of this neoplasm and now suddenly we are expecting a recurrence at the site, or when there is a suspicion of more than one malignancy, that is the suspicion of synchronous malignancy is there. The recent literature is now flooded with the evidence of PET-CT guided biopsy in tumor transformation as well as in the mutational analysis. That is, there is a known case of disseminated or the metastatic neoplasm, and it has failed to respond on the standard treatment guidelines by the standard treatment protocol by the guidelines, and now we are suspecting that there is either a mutational, there is more mutations or there is a tumor transformation. Even in those cases, the role of PET-CT guided biopsy taking from the area of highest metabolic uptake is evaluated. The contraindications to this procedure is similar to any intervention, that is the INR of more than 1.4, the platelet counts of less than 1 lakh and the hemoglobin of less than 9 grams. Now the planning of this procedure is based on the imaging of the patient as well as the patient parameters. To begin with, we first see whether this procedure is relevant to the patient or not, because this procedure requires radiopharmaceutical introduction. Second, we check the laboratory parameters, that is the coagulation profile, and also check any anticoagulants or the antiplatelet therapy the patient is on. And the guidelines which we follow for this is similar to the interventional radiology. Now for the anesthesia, we prefer the procedure to be done under a local anesthesia. But there is no contraindication to the general anesthesia also. Thus, any contraindication to either of this anesthesia is ruled out. An informed written consent is taken from the patient. The patient or the guardian is totally informed about the disease, about the procedure and any related complications or the risk that may occur. Then finally, when the patient has agreed and the procedure and all the criteria are fulfilled, the image of the PET-CT image of the patient is reviewed to localize the site of the biopsy, following which the trajectory and the positioning of the needle is reviewed, and also it is checked whether the patient will be able to lie down in that position. For example, if it's a vertebral lesion which has to be biopsied, the patient needs to be in the prone position. Whether the patient is comfortable in that position or not, that is reviewed. In the image planning, as I mentioned before, the route or the trajectory of the biopsy needle is planned, followed by the site, that is the entry point on the skin, and the type of the gauze of the needle which has to be used is confirmed. Apart from these checklist, the most important part is there is the coordination with the referring department, because we don't have the beds in our own department. So we need the bed at least for a few hours of observation from the referring department. And the emergency kit is always made ready, though it is routinely checked in the department, but still at the time of the procedure, it is kept ready. And very important thing is, throughout this procedure, the patient's vitals are continuously monitored to prevent any untoward events. Now, this is the Robio machine, and on this monitor, we plan the trajectory and the placement of the needle. This is the robotic arm, which can be moved in both the X as well as the Y axis as per the command given by the user. Once the patient is positioned and the image is and the procedure is planned, the arm automatically moves towards the site of biopsy, and following which the coaxial needle is placed. Now, this pictorial representation is just to explain how we proceed in our, how do we do this procedure in our department. Now, in this image, there is the image planning. That is, we plan the trajectory as well as the site of the needle. We decide which route to follow. Once the route is confirmed, we send the command to the robotic arm, which then automatically places itself on the patient's, on the site. Under the aseptic conditions, the biopsy is planned, that is the dripping is done with the povidone iodine and the alcohol, and then the coaxial needle is just placed in the clamp or the needle holder of this robotic arm. Once this needle is in position, the local anesthesia is administered as deep as the muscular layer. Once the anesthesia effect is evident, we introduce this needle inside the patient's body. Once the needle is inside the body, the robotic arm is retracted and a check CT is done. This check CT is fused with the PET image which was acquired just prior to this procedure. Hence, it is an intra-procedural guided biopsy or a real-time biopsy. Once it is confirmed that the area of interest is biopsied, with the help of the biopsy gun, multiple samples of the tissue are taken, placed in the respective vials, that is 10% formalin or normal saline as per the lesional characteristic, and sent to the respective department of either pathology or microbiology. Once the biopsy is done, the site of entry is tightly sealed to prevent any external layer entry. The patient is confirmed for its comfort, and again a check CT is done. Now, this check CT is to find out whether there is any associated complications like hydrothorax, hemoperitoneum, hemothorax, or pneumothorax. Once this risk is ruled out, the patient is sent to the department of department which referred to us for a few hours of observation. Now, we started doing that PET-guided procedure in the end of March 2023, and we have done around 20 patients till now, of which the known malignancy patients were 7. Among those 7 patients, 2 were for the staging, that is to know the primary disease, the primary malignant site, and 5 were for the recurrent evaluation. 11 patients were of unknown primary, where the imaging was suspicious of malignancy, and 2 patients had infectious disease. The most common site which had been biopsied till now is the lung, followed by liver and retroperitoneum. The maximum size, the average size of the lesion which we have biopsied till now is around 6 centimeter, but the smallest was around 2.3 centimeter. The average SUV max of our lesions were around 12, but all the lesions had SUV of more than 3. Out of 20 patients which we have biopsied, 17 histopathology reports are available, of which 15 are positive for the disease. In those 15, majority of patients had malignancy and 2 had active inflammation. Out of these 17, 2 patients had negative report on the histopathology, that is, a normal tissue was biopsied. So the error is 2 out of 15. In the complication rate, none of the patients had major complications requiring more than 24 hours of admission. 4 patients had minor complications, that is pain at the biopsy site or mild pneumothorax and mild hemoperitoneum. But none of the patients needed intervention for this complications, and they were managed conservatively. Now I'll share a few cases which we have done. Now this is a case of a 67-year-old gentleman who presented with right-sided chest pain and hemoptysis for 1 year. HRCT was done 10 years back, or 10 days before the PET-CT, that showed large ill-defined mass in the right lung upper lobe, suggestive of neoplastic etiology. So the patient was sent to us for baseline PET-CT and biopsy if needed. So we can see there is a large ill-defined mass with a bronchial cutoff on the right lung upper lobe. And important thing, as I discussed before, this uptake is not uniform. There are a lot of areas of necrosis within. So we directed our biopsy needle at the site of the maximum metabolic activity, and the final histopathology was squamous cell carcinoma. This is another case of 62-year-old gentleman who presented with cough and low-grade fever and left-sided chest pain for 2 months. HRCT done showed the bilateral cavitatory lesions with the left lower lung consolidation. The sputum examination and the lavage was negative for any infectious pathogens, and he was started empirically on anti-tubercular drugs as well as the antibiotics, but there was no improvement in the symptoms. With a long-standing cough, not improving on antibiotics, there was a suspicion of some underlying malignancy. So the patient was referred for the PET-CT followed by biopsy if needed. We could see that throughout the body, there is only the evidence of lesion in the left lung lower lobe and few mediastinal lymph nodes, and there was no lesions elsewhere. And even this lesion was peripherally FDG avid, thick-walled cavitatory lesion with the air fluid levels within. So we directed the biopsy at the wall of this mass that came, and the pathology report was finally an organizing chronic inflammation with no evidence of malignancy, though it was AFP negative. This is an interesting case where a 62-year-old gentleman presented, was a recently diagnosed case of carcinoma mid-esophagus of squamous cell variant, and he was sent for PET-CT, baseline PET-CT for staging. We can see in the MIP images that there is the primary lesion in the mid to lower esophagus, and besides that, there was an evidence of an FDG avid heterogeneously enhancing lesion in the left kidney, in the interpolar region. So the differentials for this lesion was either a metastasis or a synchronous primary. Hence, the patient was referred again for the PET-CT guided biopsy, which finally revealed, the histopathology finally revealed a squamous cell carcinoma, and hence the metastasis from the esophagus. This case is of a 50-year-old lady who was a known case of carcinoma cervix squamous cell variant, post-surgery and chemoradiotherapy. The baseline cross-sectional imaging was not evident of any M1 disease, but she was lost to follow-up after the treatment, and she presented with abdominal pain and constipation for 4 months. Thus, the restaging PET-CT was advised, and we could see that there is a metabolically active ill-defined thickening in the operative bed, which was suggestive of recurrence. She was referred for the biopsy, which confirmed the squamous cell carcinoma in this tissue. And the last case is of a 44-year-old lady who presented with upper back pain for 1 year associated with weight loss. The routine investigations were done and the ultrasound pelvis showed subserosal fibroid in the anterior uterine wall. And an MRI of the dorsal spine was done that showed destructive lesion in the with the paravertebral soft tissue component in the D3 vertebra. The differentials were either an infection, multiple myeloma, or metastasis. So the patient was sent for the PET-CT for further diagnosis. We can see that there is a metabolically active ill-defined mass with a lobulated outline replacing the entire uterine wall. Besides, there is also FDG-avid lytic lesion in the D3 vertebra. So in the final impression of our report, we gave the uterine lesion may be a primary with a metastasis to the D3 vertebra, and the patient was referred for the biopsy at the D3 vertebral site because there were multiple differentials on MRI, and it finally the final histopathology was a spindle cell tumor. Further, the endometrial biopsy was done that confirmed the spindle cell tumor in the endometrial cavity also. Now, the literature supports the diagnostic accuracy of PET-CT guided biopsy more than 95%, irrespective of the sites which have been biopsied. Also, there is an evidence of a very high diagnostic accuracy in case of bone lesions, that is reaching up to 98%. Moreover, in a large number of patients, it has been found that those with the suspicion of malignancy on PET-CT and with at least one failed anatomical biopsy, the diagnostic yield of PET-CT guided biopsy is nearly 97%. Also, in those lesions which are suspective of malignancy again, but they are poorly visualized on anatomical modalities, the diagnostic accuracy of this intra-procedural F18 FDG PET-CT guided biopsy is 100%. And in bone lesions, when biopsied on PET-CT procedure, there is a change in management of more than 50% of patients. Also, an important thing is about the rebiopsy, that is the diagnostic yield. As I mentioned, PET-CT guided biopsy will be helpful in even knowing whether there is a need for rebiopsy or not if the sample vial is placed under the scanner. So the literature is evident showing the need for the rebiopsy is much less with the PET-CT guided biopsy. And all the studies which have been quoted till now or in the literature have shown the major complication rate of less than 1% and a minor complication rate of less than 10%. Now, one may comment about the radiation exposure. Now, that is a very valid comment because we are administering radiopharmaceutical, and that too a PET radiopharmaceutical inside the patient. But this study which I am quoting is from an Indian institute which has done more than 100 procedures on PET-CT guided biopsy, not only in FDG, but also in other radiopharmaceuticals like PSMA and DOPA. And they calculated that in the 50 procedures they have done, they calculated that the mean procedure time was around half an hour, and the interventionist received the dose of around 2 to 3 microsieverts, and the assistant to this interventionist received around 1 to 2 microsievert per procedure. Now, this dose is very much less to the dose limits prescribed by the radiation protection agencies in India as well as the international guidelines. So, to conclude, a real-time robotic arm-assisted needle placement is a safe procedure with a high diagnostic yield and hence lesser need for rebiopsy. It has a high diagnostic accuracy. It is associated with minimal interventional related complications and also gives minimal radiation exposure to the interventionist. The other applications of this robotic arm we would like to explore in our department in future would be the PET-CT guided FNAC, which requires even a thinner needle and requires a bit more expertise. Then PET-CT guided biopsy utilizing radiopharmaceuticals other than FDG, that is Dotanoc, PSMA, FAPI, and DOPA. And we will also like to extend the utility of this robotic arm for the CT-guided procedures like pain palliation. Though there is no PET component associated with this procedure, but always this robotic arm can be utilized for pain palliation because of its high precision. In the end, I would like to thank the other faculties as well as the residents of the Department of Nuclear Medicine for their constant support and encouragement. I would like to extend my sincere thanks to the primary referral departments for this procedure, that is the Department of Pulmonary Medicine, Radiation Oncology, Surgical Oncology, Medical Oncology, and not to forget the Department of Pathology and Lab Medicine and also Microbiology, which come up with the diagnosis and help us to improve our diagnostic accuracy. Thank you very much for your patient listening.
So, my question is general questions. Miss, the dose administered to the patient is the same when you do the procedure for PET-CT and PET-guided biopsy? Dose is same or different?
Yes. So the dose is entirely different. What we administer for a whole body PET-CT for diagnostic purpose is around 0.15 to 2 millicurie per kg body weight. So it lies between 5 to 10 millicuries based upon the patient weight. But what we do in the, because that is for the SUV max calculation. But what we do in this procedure is maximum of 2 to 3 millicuries because we need to just brighten up the lesion for our needle to be placed in the site of maximum metabolic activity. So the dose which we give is much, much less than the diagnostic procedure.
Thank you, Deepanksha. That was very nice. And I think it is very encouraging that your department is now embarked on this. Looks very promising that you can take a biopsy sample and immediately do a PET and see whether I've got the sample that I wanted to. Because many times what happens when we do blinded, then probably the sample reports come after some time and we say that it's negative. So, of course, most of your work is in oncology. And so first, I have a couple of questions. One is, many of the lesions that you showed could be also easily accessed by CT. So, if you have already done a PET which is showing that the wall is showing that there is increased metabolism, maybe the same lesion, because the lesion is not going to change too dramatically over a couple of days. So maybe the same lesion in the same site can be delineated also by the CT people, and they can also do the biopsy. Unless, of course, you do a PET and while you are doing the diagnostic PET only, you decide, let us go ahead because already rest of the things have been done. So is it something like that? And what about the role of knowing the vascularity of the lesion? Number two, because I'm from neurology, so we have lesions which are in the brain. And I'm sure that you're not planning to do a robotic guided biopsy from the brain lesions. But again, there would be, suppose there are multiple lesions or there are some leptomeningeal, you're suspecting Mets, and there may some of them, or there are nodules, and some of them are enhancing and some of them are not enhancing as per the PET. Can you guide the radiology or the neurosurgeon to do some kind of a neuronavigation protocol so that they can do a targeted biopsy when they are doing the neurosurgical procedure?
Thank you, ma'am. I'll come up with the neurology question first. Now, the radiopharmaceutical which we are using here is FDG. So on FDG, as we can see in the various images, it has a normal physiological uptake in the brain. So most of the time, except when it is a recurrent disease, we can definitely guide the neurosurgeons. Like there is an area where we can fuse it with the MRI and we can guide the surgeons where to put the needle at. But PET-CT guided biopsy, real-time PET-CT guided biopsy, the only site which cannot be targeted is the brain. But except the real time, we can definitely guide whether there is a recurrent tissue and which area to be proceeded with. Now, if I come with the CT, definitely the forefathers are the CT interventions. So there is no competition with them as such. But we need to know that there are indications which are common for both the PET, CT, and the ultrasound. That's why when we are planning a procedure, I said the procedure first should be optimum to the patient. That is whether the PET CT guided procedure is optimum to the patient. Example is if it's a breast mass, and a breast mass is easily accessible to the ultrasound. So why to expose the patient to radiation? But if that breast mass is having heterogeneous enhancement and it has a heterogeneous uptake on FDGs, though it is better to do a PET CT guided biopsy in that case, irrespective of the anatomical imaging. Moreover, this what I talked about is the real time. There are times when the PET images are also taken consideration, like even in the liver biopsies or other site biopsies, it is seen which area is having a high uptake, and then we guide the biopsy needle on anatomical modalities also. So that is also one utilization of PET guided biopsy, though it is not real time. So if we are utilizing metabolic biopsies, then why not do a real time where the precision is much better than a hand? So
the radiologists have been using the PET images for its PET guided biopsy. What they do is that they do visual registration. They have the PET image and a CT image. That is one method. Other method is that software based registrations. But as she said, it's not a real time based. That is what is the difference. But this has been this procedure has been being done without this robotic arm or anything. It was being done with the radiology, and they do still. The many centers are doing it. So this robotic arm is not available at all the centers. So without that also one can manage. But this is definitely advantage because are real time based. Because you have a PET image when you do a radiological based CT guided biopsy or PET fused images. Not fused, it is basically registered, okay fine. If the software is there, the fuse, otherwise you do visual registration. At that time what happens is that patient position may change. The CT when you do is not the same position. Some kind of changes may happen, but here it is real time, so we can always target the lesion better. That is what is the advantage here. And as far as the neurology is concerned, I think we can provide the coordinates for to enter, to reach to the lesion, so that because stereotactic planning can be done. That much we can give, and then further the surgeons can use that and then guide it. Thank you.
Hello, I'm Dr. Kala from Plasticity Department. My question is not related to topic but related to department. Are we currently doing myocardial perfusion imaging or studies?
Myocardial perfusion?
Studies, I mean imaging. If it indicated, or I mean it cardiologist refer to you, or then you do it, or the patient, anybody can come directly to you?
Usually the cardiologist sent to us, sir.
Okay, so this is some indications, parameters to go with the investigations like stress MPI or resting MPI. It's just a cardiologist send and then you go for it.
I didn't understand, sir.
Do you have any parameters that these patients we should go with the investigation, otherwise we will not do?
Okay, so we have an appropriate use criteria. So there is appropriate, possibly appropriate and inappropriate. So we usually, what the patients have been referred to us, or we also see whether this criteria is under the appropriate, because otherwise there's an unnecessary radiation exposure to the patient. So when we take the history of the patient in our OPD, we do see which criteria is the patient fitting into.
The cardiologist will send, he will first do the risk stratification, then only he'll plan for the stress MPI. And we are routinely doing it. Almost on a daily basis, we are doing on an average 2 patients, or weekly we can say 6 to 8 patients. Okay, and we have other applications in cardiology like MUGA, ejection fraction estimation, left ventricular. Okay. Which one? No, 2D echo they are doing, but further on 2D echo you won't be able to get that myocardial that function. Okay, so that is what they ask for us from us. So what can they can get in the movements only, but then again, how much is differential movements or how much is which part is how much affected, that we can give it from here. That is what is the difference. Okay.
Thank you, everyone.